Yeah. McAllister.
So, like, where is this building on this one?
We're going to go ahead and get started so we can stay on time. I've been informed I'm like 30 seconds behind schedule. So thank you all for coming to our Preparing for National Accreditation Gap Analysis Training. I just want to go over a few housekeeping items before we get started. The restrooms are behind you in the hallway. There are vending machines down here, and then the cafeteria is in another building that direction. So if you need to find a cafeteria, we know people that have been there. They can give you their personal story about traveling to the cafeteria, so you won't get lost. Also, this morning's, the first part of this training can be applied to CHES credits, and what other CEU? Do you know?
I think she said maybe just like general CEUs possibly.
Okay, general CEUs. So consider that if you need to get some CEUs for your certifications. Also, just go ahead and review the learning objectives today. We're going to explain the steps in preparing for accreditation, including developing prerequisites, conducting a self-study and gap analysis, selecting documentation, and incorporating quality improvement. We're going to introduce attendees to NACCHO's QI roadmap and self-assessment tool and provide guidance on the use of both of those. We're going to provide some guidance on organizing and conducting a mock site visit to assess documentation readiness prior to submission to FAB. And we're going to familiarize ourselves with acceptable examples of documentation for accreditation. So in case you didn't know why you were here, what you're going to learn, now you're all on the same page. There's agendas in your folders. So if you want to just review that and kind of see what the day will look like, lunch is going to be on your own, and we've extended it a little bit. I don't have an agenda with me. What time is lunch? 12 o'clock, 12 to 1:10, I think, is lunch. And the site coordinator here said it might be easier to head to Moore to find something for lunch rather than going into Norman. So just take that into consideration when you're making your plans. Also, there is an evaluation that we ask you to complete by the end of the day. So be sure to do that, and then you can leave it at your desk or on the table as you came in. The note cards that are in your folders are going to be for the tribal panel. So you might feel the need to write something on it before then, but just hang tight and save those for the tribal panel, and you'll be given instructions on what to do with those. We want to again thank our sponsors for this training. The Oklahoma Public Health Association applied for a grant from the American Public Health Association, and we were awarded funding to support training and public health accreditation activities in our state. And so not only do we thank APHA, but we're also partnering with the Association of American Indian Physicians. They also have a vested interest in accreditation and are helping sponsor this training as well. Before we go any further, I want to thank the planning committee. So if you are helping to plan this training anyway, would you please stand so we could recognize you, because these are tough. I know there's more than one or two of you. Yay! Some of you aren't standing, but we do thank you and appreciate you and your hard work. And then this is recorded, so just keep that in mind when you are going throughout the day. And if you have any questions about that, just see me, I'll be in the back. Are there any questions before we get started? And I'll introduce our speakers. Super. All right, well, after me, we're going to have some Accreditation 101 provided by our very own Keith Reed. He's been with the state of Oklahoma for 15 years and the past 10 with the state health department. He served as a local public health director over several counties in southwest Oklahoma and is currently the regional director for Cleveland and McLean County Health Departments. He's received several degrees from Northeastern State University and OU, and he's a graduate of both Oklahoma and National Public Health Leadership Institutes. Prior to his public health career, he served as Lieutenant Colonel in the Oklahoma Air National Guard and served multiple tours in Operations Iraqi and Enduring Freedom. And is currently assigned as commander of the 137th Aeromedical Evacuation Squadron, Will Rogers Air National Guard Base in Oklahoma City. Thank you for your service, Keith Reed. And then our other trainers this afternoon are going to be Lowry Ward and April Harris. Lowry joined NACHO in 2010 as a program analysis with the Accreditation, Preparation, and Quality Improvement team. In her current role, she provided technical assistance to more than 50 health departments in 13 states around performance improvement topics. Prior to coming to NACHO, she worked as a program coordinator with the Duval County Health Department in Jacksonville, Florida, and her work there included managing and coordinating community-based coalitions and developing materials for the community and public health professionals, and she has a Master's of Public Health from the University of South Florida. All right, April Harris is the Community Health Manager with the Three Rivers District Health Department, where she's been for 8 years serving in different capacities in the roles of health promotion, policy development, preparedness, and accreditation preparation. Her primary responsibility in the past 3 years has been working with her agency to achieve and maintain public health accreditation. Three Rivers was one of 9 local health departments in the first national cohort of applicants, and she's responsible for quality improvement initiatives throughout the agency and manages the Three Rivers MAP process in their 4 counties, which is in its 2nd iteration. She got her Master's of Public Health in Health Services Management from the University of Kentucky, and is co-chair of Kentucky's accreditation workshop. So I'm gonna let Keith come up and take it from here, but let's go ahead and thank all of our speakers today.
I guess we have to use the microphone if we're recording it? Yeah. Oh well. Okay, well, I'd like to thank Dana, for inviting me to speak today. I was pretty excited about it. Glad to be here. Welcome everybody to Cleveland County. For lunch, I probably ought to mention, don't go up near the health department anymore. It's 4th Street. Water's going to be off today. So if you make a trip up there, find that special restaurant, hopefully it'll be closed down because there's no water. All right, so don't go that direction. Save the trip. Asked Dana what she wanted me to talk about. Of course, she gave me several bullet points because she's so organized around accreditation. And I realized that I typically kind of get pigeonholed to talk about accreditation in Oklahoma, so I thought I would just kind of ignore what she said and talk about what I wanted to talk about. So I'm going to deviate and talk about the military for a little bit. And it kind of ties in, but I was asking myself, why do I love accreditation so much? And I kind of went back to my military career. I spent more than 20 years in the Air Force. And I can tell you right now, as commander of the Aeromedical Evacuation Squadron, every single month I had to submit a report to the Air Force, the Air National Guard, and our wing that explains how we are ready to execute our mission. It describes our readiness scores. It tells them where we rank and what the gap is, if you will, between where we're currently at and where they expect us to be at. And it establishes whether we're war ready, quite frankly, or whether we're ready for our home mission. So, as you can imagine, I care a lot about readiness statistics and the data that go into describing how we're able to do our job. Air Force will not accept from me just my word that says, we're good to go. Don't worry about it. Trust me. I know what we're doing. We're fine. They won't accept that. I tell them that. They say, okay, stand down. Because you can't prove it. You're not ready. We're not going to take a chance and send you out. And our military forces deserve better. And the citizens deserve better. So when I took my first job as a director of the Comanche County Health Department, first thing when I walked on the job was I wanted to know, okay, what's the standard? What are we trying to achieve, and what goals are we trying to meet, and how do we prove that we're ready to execute the mission? And quite frankly, at that time, 2008, there really wasn't anything. And that caused a lot of anxiety for me because I did it different in the military, and it was was about the standards. It was about proving you could do the job. Fortunately, my anxiety was relieved a little bit when FAB came forth and offered up the beta test for accreditation, and immediately jumped on the opportunity to apply for that so that we could, even if it was just a beta test, it was something that put forth the national standards that we could go through and do an assessment, evaluate our efforts, and determine whether we were ready to serve the citizens and do it at the level required. So we jumped on that opportunity. We went in and we learned that we were falling short in a lot of areas, to be quite frank. And I'm pretty sure Dana actually asked permission if she could share some of the shortfalls that we found and share some of the failures, quite frankly, that we came across when we were trying to do that and do our assessments. Like, absolutely, because that was the whole purpose. That's what we learned going through and doing an objective self-assessment. We figured out we're not meeting the citizens' needs in all 10 essential services. We're not doing what we need to do as a public health agency. And that's not easy to tell yourself, and it's not easy to tell your staff. It's nothing to take offense at. It's just the reality of public service. We have an obligation to take care of the public. They have an expectation of us. They pay their taxes. They expect a public health professional organization to provide those services at a readiness standard that will meet their needs. So it's one reason I love accreditation. It provides that objective assessment. It gives us a range that we can go through and evaluate ourselves and determine where are we at and where is the standard and how do we make up that difference? How do we close that gap? Second reason I love quality improvement, because it's the method by which we close the gap. It's the way we improve how we are as public health servants. So for my 5 minutes, I just want to get up here and tell you, love public health, love accreditation, and I know some of my counterparts get tired of hearing me talk about it, but that's okay. I believe in it. I'll continue to talk about it. And if you want to catch me in the hallway and talk about accreditation, I'll bend your ear. I'll enjoy it. All right, so I've had the pleasure of working with Lowry for several years now, going back really through you start with the beta test?
I started making 2010 to the end of the beta.
At the end of the beta test, that's right. And then met April at a few conferences and listened to her present. We were in competition. I'll go ahead and say it, April. We were in competition with Three Rivers Health District out of Kentucky to be one of the first cohort to achieve public health accreditation. They were accredited with that same cohort, but I'll say it again, if you look at the list of the first 11 health departments, Comanche County Health Department was number 1. I don't care if it was alphabetical, we were number 1. Sorry, April. Lowry?
So I didn't include it in my bio today, but I did my undergrad in Georgia, where much to the chagrin of my British mother, I picked up the term y'all. And since starting at NACCHO, I've been taught not to use that in a professional setting, but I feel like if you can't do that in Oklahoma, when can you do it? So good morning, y'all. And thank you so much for having me. As Keith and Lynn said, I am Lowry Ward. I am with the National Association of County and City Health Officials on our accreditation preparation and quality improvement team. And we have been involved with FAB since the very beginning of it. We were on the group that helped found them. And I have been really fortunate to work with several health departments across the country as they get ready for accreditation. So my first presentation this morning is just about very generally how to prepare. So it's some big picture things, some components of national accreditation and the process. I know that we have mixed knowledge levels in this room, so some of you, this will undoubtedly be review for, but keep in mind FAB did just update their standards to version 1.5, And this presentation involves some of those updates, so even if you are sort of old hat at this, there will be new info. And then those of you that are very new to this might seem a little overwhelming because it's a lot of info, but just talk to any of us that have been doing this a while and we can help boil it down for you. Another disclaimer I have to give is that NACCHO, the organization for whom I work, is not FAB. We do not accredit. We are in no way part of the decision that the board makes about the health department's accreditation process. And because of that, we cannot provide technical assistance around things like standards and measures interpretation or the electronic system that FAB uses, things like that. That is very much on their side of what we call the firewall. NACCHO helps people prepare, so develop documentation, think about quality improvement, things like that. April and Keith and Dana, for that matter, have gone through the process and can answer some FAB-specific questions, but typically we defer folks to FAB for technical questions like that. All right, so with that, I'm going to get started. The objectives of my first presentation today are to describe, and these slides are in your folder, if you want to follow along, to describe the key steps in accreditation preparation, to share resources available for QI and accreditation. Part of my job is to create things to help you all do your jobs. And then to share some lessons learned by others. I've been fortunate enough to work with pretty much 75% of the first 30 accredited local health departments, so I've gained lots of valuable insight from them. An outline of how we're going to go through today's first hour and a bit is we're going to start with the prerequisites, which are the basis for a lot of your accreditation work. Then we're going to talk about the self-study process, which is how you sort of create an accreditation team, how you guide your health department through figuring out where you are and what you have to do. And then a little bit about engaging the governing entity, and then we'll segue into the quality improvement part of today's presentation, which will involve an activity. So you won't be listening to me for the whole morning. Okay, so the prerequisites for accreditation, which most of you likely know, are a community health assessment, a community health improvement plan, and an agency strategic plan. FAB's first domain focuses on assessment, so the community health assessment is in that first domain. And then the community health improvement plan and agency strategic plan fall in domain 5, which is focusing on planning. So as I said earlier, this presentation refers to the Standards and Measures version 1.5, which become mandatorily effective July 1. So health departments that apply as of, I think, next week, June 2nd, have to follow 1.5. A few of you in here might have already applied under 1.0, so keep in mind there are some small changes, but I'm under the assumption that most of you will be applying under 1.5. So why does FAB have prerequisites? And prerequisites are just what they sound like. Before you can even apply to FAB, you have to prove that you have these 3 documents. And the reason that these are in place is because they provide an excellent measure of addressing the health needs in your community. So they're not just documents that you leave on a shelf, they're how you think about how you serve your community. They are also the foundation for a lot of the other documentation. So your health assessment, for example, leads into a lot of the research that you do, a lot of the publications you make in your health outreach, a lot of the coalitions you work with are set up around this health assessment. They identify needs that you have and that you are there to fill for the community, and they're a springboard for what you're going to be doing for the next 5 years of accreditation and beyond. So anytime you're sort of pulling your hair out as why do I have to do these things, they're much more important than just for accreditation prerequisite purposes. So unfortunately, they're not 3 discrete, isolated processes, right? It would be nice if we could just do a CHA 1 month and not think about it anymore, and then do a strategic plan and not think about it anymore. But they have to work together, and they have to inform each other. And this is something that has always been one of the goals of public health accreditation and is definitely becoming more of a focus as the standards and measures evolve. So for those of you that have reviewed the changes FAB made between version 1.0 and version 1.5, you'll notice a lot stronger languages around these linkages, and that's important, right? That's the purpose of us doing this work. So your community health assessment has to inform your community health improvement plan, and then your agency strategic plan is your agency's piece of that community health improvement plan. So there's no specified order. You know, if you are well underway of one of them, it does not mean that you have to go back and start all three over again. But it needs to be in your thought process as you're guiding these initiatives of how they're going to be linked. So in the wonderful world of public health jargon that we use, we say CHA and CHIP for Community Health Assessment and Community Health Improvement Plan, and those are part of the Community Health Improvement Planning process, which is CHIP with two P's. And at Asia we have a division called CHA-IP, which is Community Health Assessment and Improvement Planning. But so just so you all know, when I'm talking about the Community Health Improvement process, I'm talking about both documents. They inform the Community Health Assessment informs your Community Health Improvement Plan, and working on those is the Community Health Improvement process. So FAB does not require a certain process. A lot of folks use what NACHO uses the gold standard, which is the MAP process, mobilizing action for planning and partnerships. But there are several other methods or frameworks that are used across the country. In the latest version of Standards and Measures, FAB actually mentions a few frameworks and then a few resources for those frameworks, which the language is much clearer. NACHO was a big fan of that change. But pretty much all community health improvement planning process models include these 8 steps. And they involve steps I'm sure you're all aware of because of your work, things like engaging the community, having that vision in place, like what you're actually working to do, conducting the assessment, and then prioritizing the issues, because unfortunately we can't solve all the problems, and then developing that plan, implementing that plan, and monitoring and evaluating that plan. And these are things that are have always been involved in this process, but have become required by the FAB standards throughout their development. These are some frameworks you might have heard of. In the 1970s, when this work was very, very early in its development, we learned and used what was called Proceed model. That has, gave way to Patch and Apex, which some of you might have worked with in the 90s. Apex had a branch off for environmental health called KCH, which is still used in a lot of health departments, but is a little outdated for obvious reasons. And then MAP was developed by a huge work group from the field in 2001. NACHO and CDC led that work. And the handbook has recently been refreshed to include a lot of pieces related to accreditation. As I said earlier, NACHO views the MAP framework as sort of the gold standard in community health improvement planning. We know that not every health department can conduct a comprehensive MAP process, but we encourage you all to think about sort of what you lose when you don't do a MAP sort of with all of its components. Another method specifically mentioned in FAB Standards and Measures version 1.5 is the Achi Toolkit. The Association for Community Health Improvement is a nonprofit organization that specializes in working with nonprofit hospitals who, as you all most probably know, are required by the ACA to conduct community health needs assessment every 3 years. And so because FAB requires community health assessment every 5 years, many communities have sort of done that work together, so they're not reinventing the wheel. And so the ACHI Toolkit provides a really great framework if the nonprofit hospital is going to be leading the assessment or very highly involved. So if any of y'all are in that situation, I encourage you to consider it. And then there's a few state-specific models and frameworks out there, and then a couple of other national models that FAB included in the 1.5 revision. So, any questions before I jump into the individual prereqs? So a community health assessment, according to FAB's glossary, is a systematic examination of the health status indicators for any given population that is used to identify key problems and assets in a community. So I know we have a lot of tribal health folks in the room today, and the tribal health assessment is obviously a different consideration than a local one in terms of who your jurisdiction is. So as I go through some of these points, keep that in mind. But typically whatever jurisdiction your health department serves, so the one that you are choosing for your population size when you apply to FAB, is the assessment that needs to be addressed by your community. If your community is working in conjunction with a hospital, like in the example I just mentioned, there's sometimes not direct overlap and of the population. And FAB has said publicly that they don't want to force you to do two separate assessments. They just want to see evidence of how the community you serve is sort of mentioned specifically in that document. So if the local nonprofit hospital takes the lead in developing the assessment, how are you then using that to apply it to your jurisdiction? So there's specific language around that, but FAB is willing to discuss with you if that's the case for that. Okay, so in the FAB Standards and Measures version 1.5, Standard 1.1 says Standard 1.1 focuses on participating in or leading a collaborative process resulting in this comprehensive CHA. Measure 1.1.1, which is the same for tribes and locals, is a partnership that develops this CHA, and Measure 1.1.2 is the actual document, so the physical community health assessment. And then 1.1.3 is how accessible that CHA is to your community, other agencies, etc. So there's three components of the overall CHA requirement. The CHA process, so that Measure 1.1.1, requires a participation of representatives from a variety of sectors. So the point here is to make sure that it's not 10 people from your health department and one person from the YMCA doing this entire initiative. So you have to document with a membership list which organizations are involved, and then you have to prove that you've had meetings, and these can be emails. They don't have to necessarily be in-person meetings, but that a diverse group of members meet regularly. The documentation of these meetings, again, can be meeting minutes, emails, agendas. Everything in terms of FAB documentation needs to be, it's no longer the term, they're not using the term signed anymore. They're using the term authenticated, I think, now, so has to be, the agenda has to be on like letterhead of the health department. You can't just have a Word doc that says meeting from May 4th or things like that, but we'll talk a little bit more about that later. And then the process that you used. So again, you need documentation of the framework that you used. The two I mentioned earlier were MAP and ACHI, and then the other two that FAB added this year in the Standards and Measures 1.5 are Assessing and Addressing Community Health Needs, and then the University of Kansas Community Toolbox. So the actual document that FAB requires you to submit, which would also be your prerequisite here, it needs to be 5 years old or newer. The data needs to come from a variety of sources. It needs to include information about the demographics of your population. There needs to be a description of the health issues, a description of the factors that contribute to those health issues with a new focus on health status disparities, health equity, and health high-risk populations. That's new in 1.5. And then a description of the assets available. So not just what's wrong, but what you have to work on it. So the biggest change here from 1 to 1.5, which is, a change in the right direction in the field. We want to see more focus on addressing health equity in these community health assessments, and so that's in bullet point 5 on this list. There's also a requirement that the local community have an opportunity to review and contribute. So you have to document that before this document became final, which we all know they're never final, but you all know what I mean. that you shared it with the community and got their feedback. And then you also have to prove that you are, constantly monitoring or refreshing it. You don't have to produce a new one until the next sort of 5-year mark, but you do need to, show that it's not just sitting on a shelf. And then once you're done with this CHA, you have to prove that you distributed the findings to the public and to the partner organizations with whom you work. Okay, so now on slide 19. When you're conducting a community health assessment, the first step is always to have a plan to conduct this assessment. You can't just sort of start anywhere. And then this slide lists what else you need to do to develop this document. We include aligning your community vision with the assessment just because pretty much every successful partnership we've seen that's developed an assessment creates a vision. FAB doesn't require it, but we just find that it develops a lot of group morale and group think around addressing this collectively. And the reason it's important to have, your entire community or public health community working on this together is because of, the jelly bean diagram, which I'm sure you have all seen. But when you are developing a community health assessment and then a community health improvement plan, you need to consider what is called the local public health system and not just your health department. So you might be leading it, or a hospital might be leading it, but there's, a million other groups that you need to engage either directly or through some of these other key partners. So when we talk about MAP, we have what's called a core team, which is typically a health department, hospital, health planners from nonprofit orgs, groups like that, and each of those members of the core team will bring in, some of these other nonprofits that can contribute. So as I showed you earlier, FAB requires a diverse partnership, and a lot of times folks will use this diagram as they're thinking about developing that partnership. If you wanted to make something like this for your community, Franklin County out of Kentucky, also in the first cohort of accredited health departments, they took the time to go through and put like actual local names in this diagram of folks that were going to be at sort of the first MAP kickoff meeting. And it took Judy, their former accreditation coordinator, talks about how it took a lot of work, but it was really worth it because folks were like, oh look, there I am on this poster. So just something to think about. There's also a great tool, partnertool.net, where you put in your agency names and some other groups you work with, and they'll make a similar diagram for you, so it can be electronic. And obviously, to conduct your health assessment, you need data. Because Oklahoma is a centralized state, you all are, very lucky to, get a significant amount of this data from the state. So I'm not going to spend too much time on this slide, but there's, also really great national and local sources of data available out there for when you're adding, some diversity to your CHAs. And then universities and, nonprofit hospitals and managed care organizations are typically, required to or willing to share some of their info. So just some things to think about. Because I know a lot of times the biggest concern with developing a CHA is there's too much data, how do we pick what to use? And so that's where some other folks in the state that have gone through this before can be helpful. These are some resources that, we recommend from NACCHO. This is my project's website. I'll talk a lot more about that later. And then we also have a pretty robust CHA and CHIP resource center where we include examples of what we view as high quality CHIPs, and then also CHAs and CHIPs, and then also just a lot of resources for the different phases. So if you're having your first partnership meeting and you don't want to have to create a charter document, we have some from other communities that have done that. The MAP website is where you would find the framework if that was the plan, the framework you were going to use. And then that process I talked about earlier for working with your local nonprofit hospital. Okay, so your CHIP, according to FAB, is a community health improvement plan, is a long-term systematic effort to address public health problems on the basis of the results of the CHA activities and the community health improvement process. So any questions on the CHA before I move to the CHIP? So as I said earlier, standard 5.2 is where FAB couches the chip. The overall standard is to conduct a comprehensive planning process resulting in a tribal state community health improvement plan. The first two measures here are just for locals, but there are measures for tribal health departments that are very similar. The first measure is to develop a process to develop a chip, similar to the last one we discussed. The second measure is the actual chip. The third is elements and strategies of the health improvement plan implemented in partnership with others, so that's how you're working on the chip. And the fourth is how you are monitoring and revising it. So again, in that first requirement, you have to show a broad participation of community partners. So this will probably be the same group that does your CHA, and a lot of folks use similar documentation here. But if the group changed somewhat between developing the assessment and moving to the planning phase, that would be documented here. Information from the community health assessments needs to go into your chip. So there needs to be space in your chip indicating how you use the CHA to develop it. Issues and themes identified by stakeholders in the community, which is sort of how you worked to identify what the major areas you were going to focus on were. And then the process to set those health priorities, and then what resources exist to address them. The actual document needs to be dated within the last 5 years. It needs to include, and this is a slightly new language from 1.5, desired measurable outcomes or indicators of health improvement and priorities for action. Strategy should be evidence-based or promising practices. So in the last sort of round of requirements, they included language about smart objectives and things like that. And so now they sort of rolled that all up into this desired measurable outcomes of health improvement plans and priorities. So as you get further into the guidance, they explain that you need to show how these are measurable outcomes, how you are going to track their progress and things like that. But they did change some language a little from 1.1 to 1.5 around clarifying this. You still need to discuss how policy changes can help accomplish those health objectives, and then who is responsible for doing what. And then you still need to, this was in the language has become a little clearer in 1.5, but you need to consider state and national priorities. And obviously, because of the nature of y'all's linking with the SHIP in Oklahoma, this one is typically easier on the state level, but there needs to be indication of, dealing with Healthy People 2020 and national priorities like that as well. And then the last measure in standard 5.2 is to implement the CHIP. And so you need a process to track actions taken to implement the CHIP, and then implementation of the plan. So how you're implementing it, how you're tracking what's going on and who's doing what. And then, this is the last one for standard 5.2. Monitoring the progress. So you have to report on the progress, and this is newish in 1.5, on an annual basis. And it needs to be related to health improvement indicators, as mentioned earlier. And then there needs to be this sort of annual review and revision. And they added language that if the plan was adopted less than a year before, the health department must include one of these two things. So that was a big criticism of version 1.0 was that folks that had a brand new CHIP or a brand new strategic plan, how did they show this implementation piece? And so this is now how FAB has addressed that. So if you are working, which I don't think in Oklahoma if you are, but if folks are working on a new one, this is how you document that. And again, this is just a list of some more resources. These are the same as the ones for the CHA because nature views it all as one process together. Okay, so the third prerequisite, any questions before I move on to? So the third prerequisite is the agency strategic plan. And so when I say third, again, I mentioned this earlier, but I do want to stress there isn't a prescribed order here. Typically, the health departments I work with, the strategic plan is the last piece that they do, just because they want to make sure that it represents the agency's piece of the CHIP. But a lot of folks that I've worked with, if they have a new health director coming in or a new governing board or something like that, strategic planning is a great way to engage senior leadership. So if the time is better for doing a strategic plan, there's no requirement that it needs to be done third. So this is the definition of a strategic plan from the FAB glossary, and also from a journal article published in 2008. And again, as I mentioned earlier, there's a place where all three of these documents overlap right here in the middle, and then there's places where, two overlap, and then places where they have their own importance. The standard 5.3 is to develop and implement an organizational strategic plan. And the first part of that is to develop the process, adopt the plan, and then implement the plan. So measure 5.3.1a, which is the process. The requirements that FAB has are that management needs to be involved, the governing body needs to be involved, and then the steps must be defined and described. In terms of having an outlined process, there's a lot of these available. It's not like CHIPS where there's really only a handful that you can use. Many states have separate ones, lots of universities have strategic planning processes. There's just common elements to all of them. But FAB does require that the governing entity be involved in some capacity. The requirements for the actual document are, again, 5 years. You need to include your mission, vision, and values, and how those were developed. You need to set strategic priorities for your health department. NACCHO doesn't recommend having any more than, well, we say no more than 5 to 7. Most of the folks I work with, 5 is plenty. These are things you're actually going to be able to address within 5 years, so bear in mind. Again, you need measurable time frame targets for the objectives that you develop. You need to consider key support functions required for efficiency and effectiveness. This is some new language in 1.5 that basically just clarifies a lot of the stuff that was in the SWOT analysis piece. So having a SWOT analysis is one thing, but you actually have to do a little more explanation of what you're going to do with the SWOT analysis results. And so this number 6 right here is that SWOT analysis. So you have to identify external trends or events or other factors that may impact your community health or health department. You need to assess the strengths and weaknesses. You need to link to the CHIP and the QI plan. This is one of those things that is also, this linkage is getting to be more important as the standards and measures evolve. So we're seeing better and better examples of that now, and a lot of good examples on NACCHO's website show that linkage really well. A lot of folks will have an actual strategic priority about performance improvement to show the linkage with QI. And then you need, that third measure requires annual reports on the progress towards goals. So this is just sort of a way to think about the vision, missions, and goals, strategic issue formulation, and then how to implement it. NACCHO has a really great resource that is called a strategic planning guide, a guide to developing strategic plan in a local health department. And we developed it with Illinois Public Health Institute, specifically set up around the FAB standards and measures. So it's for version 1.0, but we're going to add a page shortly with a few minor changes that are coming into play because of 1.5. But there's lots of great visuals in there that we provided full page forms so you can sort of project them when you're working with the group. Because something we found when we were conducting research to develop this guide was that sort of upper level management, governing entity people, they're very big picture folks, and they love visuals like this. And so there's several of these. I think I have one more in here in a minute. But this sort of shows how they all relate and work together and cycle around to create a strategic plan. Your mission, vision, and values, being a centralized state, there's sort of less freedom in this, but these are just some examples of ones we've seen in the field. The mission is what you do, like your purpose, what you do and why, and then the vision is like a futuristic view. And so these are some good examples of health departments that have led this process in their agencies. Northern Kentucky was in that first cohort of accredited health departments too, and then Madison are pretty far along. Oh wait, no, it was Madison, Illinois, sorry. Okay, so again, part of the strategic planning process is to conduct a SWOT or SWOT analysis and an environmental scan. And the reason for this is because your strategic plan needs to show that you considered things like, agency budget cuts, state requirements, things like that. And it's not just pie in the sky goals or objectives. So internal, oh wait, sorry, I'm on the wrong slide, this one. Okay. The internal pieces of that are your strengths and weaknesses, and then the external are the opportunities, threats, or challenges. So these steps right here are what the group will go through together in the strategic planning process. And now I'm going to go backwards just to be confusing, sorry. And then your values need to link to your mission and vision, and these are examples from Northern Kentucky, which was the vision I just showed you all. Sorry about switching that up. Okay. So again, you need to have data sources for your strategic plan, much like with your CHIP. But obviously for a strategic plan, which is an internal document, they are different. So when you're conducting a strategic planning process, which is typically sort of a 1 day, maybe 2 day management retreat, you want to bring this data and find a way to share it with the folks involved. Something that we've heard a lot from the field is if it's at all possible for a strategic planning process to bring in a external consultant facilitator for the process, because it's something that it's hard for folks who are internal to that agency to sort of not be vested in the process themselves and to jump in and share their thoughts. So it's obviously not always possible, but that is something that most of the folks we've worked with have said has been very valuable, because that person can remain very objective and work with senior leaders and sort of help bring them down to reality in certain instances. Okay, and so then once you've done all that, you have to analyze the results and pick those priorities. So, these are the questions you sort of ask as you're conducting this process with leadership in your agency. And the next step is to develop those strategies, goals, and objectives. And FAB requires that the objectives you develop be SMART, which most of us probably know this, but it never hurts to repeat it. It means specific, measurable, achievable, relevant, and time-oriented. And so you need to, develop a measure of change, in what, by whom, and by when. So those all need to be included in your objectives. And then the last sort of part of developing your strategic plan and documenting it to FAB is you need to establish a process for monitoring and implementing, typically on an annual basis, can be more often. You need to provide linkages to your QI plan, which typically means using QI to improve the processes. You need to maintain flexibility in the plan, communicate successes, and then revise and update as needed. And so NACCHO strategic planning resources, that link is way too long. You can just go to nacho.org/prerequisites. But we have this how-to guide I mentioned that's available for free in PDF version, but you can email me and I can send you a hard copy as well. And then you can print out the worksheets that go along with that, just so you don't have to reinvent the wheel by creating worksheets. And then we also have some webinars where folks have talked about how to do this process. And as I said earlier, our strategic planning guide specifically includes the FAB requirements and then worksheets. There's a lot of great frameworks out there that you can definitely meld to fit the FAB requirements, but ours lists them out specifically. Okay, so prerequisites done. Any questions? Easy, right? Okay. So now we're going to talk about the self-study process, which we no longer say the term self-assessment. Well, in accreditation, HO still says it in QI, but apparently it sounds like too much work, so we try to say self-study now. These are the steps in a self-study as you're getting ready to prepare for accreditation. You're going to form a team, develop a plan, get that documentation ready, analyze where your strengths and weaknesses are, prioritize those areas, and then implement the quality improvement piece. So when you're getting ready to develop your accreditation team, which most of you are probably here because you are on these teams, but you are probably familiar with the fact that you have to orient the staff to this concept. You have to pick an accreditation coordinator and then select the team. Why do we orient staff? We orient them to demonstrate that there's leadership support for this. The biggest thing that we see for health departments that successfully, conduct quality improvement and apply for accreditation is you need 100% leadership support, and if it's not there, it's just going to slow down the process significantly. We recommend holding an entire department-wide orientation, which explains why you're pursuing accreditation, provides an overview, explains the process, and explains to people how it's going to affect them. We have a template for this on our website, so you don't have to sort of create it from new. And I know April's done this. Like, there's lots of folks. Dana probably has one that she did. And then you need to constantly keep people in the loop of where you are in the process and what's going on. Again, these are the responsibilities of the accreditation coordinator. There needs to be one person, and it can't be the health official, that does all of these things, not just when you've actually applied, but leading up to the process extensively. These are some knowledge, skills, and ability. These are taken out of FAB's guide to being an accreditation coordinator. Some considerations that we found at NACCHO are, so this piece, the number of FTEs needed for this process varies. So obviously when you're in that year where you're uploading documentation, this person is going to be pretty much their primary job. Typically the year before, depending on where you are with the prereqs, also might be a full-time job. A lot of folks though, right up until they actually submit their application, a person is only 0.5 to work on an accreditation, so that changes, and so think about the requirements at your agency. The FAB has online trainings that this person and the health director need to attend. And then FAB has an in-person training, and then the accreditation coordinator needs to be present for the entire FAB site visit. Once you have your coordinator, you need to select your team. We found that it's very useful to have the team in place as early as possible, even if folks are added in later. Having a group set up as the key folks for staff to come talk to if they have questions is important. You need to consider things like longevity, experience, and then multidisciplinariness of the team. What does the team have to do? Some of you all that are newly appointed to accreditation teams are probably wondering this yourself. The team is in charge of collecting, identifying, and organizing all the documentation. Sometimes they're going to have to create stuff, but typically the job of the team is to go find who needs to, logically create it and work with them to do it. They need to analyze the results of this gap analysis and the mock site visit that April's going to give us more details about later. The accreditation team are going to be the folks that identify where we need to improve things, where we need to just focus our QI efforts. And they need to 100%, be positive about this process. If they need to be the champions, if your team isn't excited about it, no one at the health department is going to be. So as the AC, it's important to keep morale up on your team. And as I said earlier, they're important they're required to share information with all staff. You need to identify them early. Okay, so the accreditation team typically consists of a combination of the following. The health director often sits on the team. The accreditation coordinator has to. You'll see teams that are predominantly senior management and some teams that are predominantly frontline staff, and some are a mix. So the considerations in determining what makes up your team typically have to do with, the same standard things: the size, the organization structure, how tasks are delegated, and then how far you are along in the self-study. So these right here are pictures of a few teams. This top one is April's team, Three Rivers, and they were predominantly frontline staff, her accreditation team. This one right here is Columbus, Ohio's Columbus Public Health recently accredited team, and they were all the senior managers, so it was like the 12 division chairs, and then the AC. And then this is the chair at, the former chair at Sedgwick County in Kansas, and they were a mix. They had they're still going through the process, 4 frontline staff and 4 senior managers on the team. So again, whatever considerations your agency has is how you decide things like that. So we have some resources on our website, including that 101 training for when you're letting staff know what this is. We have a guide to the self-study process, which goes through the steps on this slide, and then links to the FAB resources that you will share with everyone. Okay, so you have your accreditation coordinator, you have your team, now you have to develop a plan. So the requirements of the AC and the team are to delegate responsibilities, train each other, and develop a timeline. When you are training your team, you are going to want to, obviously include an overview of the FAB process, go through the standards and measures, what they, how they were developed, what they include, the purpose of the self-study process, describe the FAB materials, and then set clear roles and responsibilities early. Is your team going to, just work on one domain each, or are you going to have, 3 folks who work on 3 domains and they can sort of figure it out on their own? So there's different structures that work for different agencies, but this sort of stuff needs to be developed early, along with a timeline, which is, how you're going to work with the results of your gap analysis. So if you you're going to really have to work on domain 7 and 5 over the next year and a half, whatever time you set, you need to create a schedule and stick with it. And remember to be realistic. We all know that stuff takes a lot longer than we think in our head. So when you and your team are setting these deadlines, add a little room for padding in your head so people don't get discouraged when they miss them. This is West Alice's plan. So Terry Brandenburg was their former health commissioner. They were also in the first cohort for accredited health departments. And he had a 3-year plan. For those of you that aren't aware, West Alice have been sort of pioneers in the performance improvement field for a long time, but when the FAB standards, came out in the beta test version, they were, much like he was saying earlier, there's areas where we're falling short. And so he set he wanted to set really, really doable goals, because this was before FAB had even released the real standards and measures. And so he said, for year 1, we're going to be at 40% of, the documentation required by the beta test. And then year 2, 80, and then year 3, 100. And he said it really helped his staff, 1, realize that they were bought in over 3 years, but 2, realize that, okay, they don't have to, completely change their lives for a year to get everything ready. So, obviously if you're on a tighter timeline because of pressure, from the district or the state, this has to be changed, but, think about your overall timeline before you set goals. Okay, so then the fun part, selecting and organizing all this documentation. You have to obviously have a process for this and then actually send folks out to gather. Okay, so for version 1.0, FAB has a documentation guidance document, but for 1.5 they do not. They just put all that info into the beginning of 1.5. So if you're sort of early in the process and planning to apply under 1.5, you don't need to look for this document. It's going to be gone soon, but everything will be in the newly formatted version of the Standards and Measures 1.5. All right, so then you've got to think about how you're going to store it. And we really recommend thinking about this before you even start, because if everything's in a folder on your desktop and then you have to move it somewhere else, it's much more of a pain than thinking this out ahead of time. So I'm going to show you some examples of how different folks have done this. So there's options for sharing, there's options for holding all your documentation that include file sharing. Some that we see are shared drive, at work, which, Dana, that's what you all did in PhD, right? So that, this is definitely sort of, I would say, the most common. Second most common is sort of like a cloud, so folks can, a lot of health departments in more rural areas where folks use like their home computers more and things like that, they use a cloud so they can get to the documentation offsite. And then we're starting to see more folks using SharePoint as SharePoint improves its capacities. These are some things that we don't recommend as the primary way to store your documentation. They can be used as secondary ones, obviously, but some folks use just eFab. So eFab is Fab's system. So once you've applied, you have access to eFab. And some folks did not store it anywhere else. They just put it in eFab and then dealt with it there, and that did not go well, so we don't recommend that. Some folks keep hard copies of everything, and that's fine, but make sure it's not your primary way of storing it, because when you lose something, you can't get it back. And then we've just heard horror stories of everything being on someone's desktop and being lost. So again, backups, these are fine, but make sure you have a way to keep them on the network. This is Clackamas County, and they are using SharePoint. Clackamas County in Oregon, and they are, I think they just had their site visit. And so this is their, they've taken I think it's SharePoint, the new version, and then just created their own portal for this. And so it's much like a shared drive in terms of organization, but it's on SharePoint, which they can then access on and off site. And then they have, folders for each standard, measure, required documentation, guidance, narrative, things like that. This is Columbus Public Health System, and this was all on their shared drive. They had a folder that the accreditation team had access to, and then the folders that were within these folders that had specific pieces of documentation, only Lori, their coordinator, had access to like deleting something from those. So you have to think about restricted access for some of these folders so that someone has the final say in what goes in there. This is Franklin County, Kentucky, similar thing, only instead of having a domain folder and then a standard folder and then a measure folder, they just made folders for every single measure because they found it was easier for them instead of having to go down into a bunch of levels. And so again, that's you as the accreditation coordinator, if that's your role. This is pick what works best for your brain. This way, a lot of people get really excited about this slide, it scares me. This is in Spokane County, Washington, also one of the first accredited health departments. They used a system called MindJet. Full disclosure, they are switching to SharePoint, but not because they didn't like MindManager, just because the state is now paying for SharePoint. But so they bought this software called MindManager, and it's like a visual way of organizing documentation. So instead of folders, you have like the circle that says measure 1, and then these are all links to documents. And so if any of you like the idea of this, they have a template that they made that I can send you that they like to share with people. So, and MindManager is not horribly expensive. I feel like it's $340 for one license for a year or something like that. But it kind of creates a cool picture, but it scares me. Okay, this is Barren River in Kentucky, I believe. So this is, this is just the standard FAB spreadsheet, right? So they're in the process of updating this for version 1.5. The FAB has a spreadsheet that just includes a box for every single measure. And a lot of folks will go through and just do a hyperlink to the piece of documentation they have that meets this requirement. So a lot of folks take the spreadsheet and just adjust it to a way that works for them. So this is Barren River's example of what they did. They just added a few columns for who's in charge of this, when does it expire, things like that, just to make the spreadsheet a little more useful after they have conducted the process, and then a column for sort of if it's complete or if it still needs work. And then Missoula in Montana, recently accredited, they did a similar thing. They added a few columns for who has responsibility. If they had options that were like secondary, that were almost just as good, but they chose another one, they wanted to keep that second choice in the spreadsheet, so they added a column for that. And Cook County, Illinois, they were one of the first ones I met who added a column for feedback from reviewers. So they basically are still using the same spreadsheet, and they included stuff from their mock site review and from their fab site visit in there. And this spreadsheet is obviously getting huge, but it's just some things to think about adding as you develop your organization system. Okay, so when you're selecting documentation, after you've thought about how you're going to store it, you obviously need to pick stuff that's relevant. Fab's guidance in 1.5 is a lot more clear. That was their biggest change in this iteration, is if they got questions from the field, certain measures had tons and tons of questions. They said, okay, what are we saying wrong? We gotta fix it. So that's an advantage for this. Some things to consider: do not submit more than Fab asked for. If they ask for 2 pieces, only submit 2 pieces. April's been a site reviewer, and I'm sure she can tell you she doesn't want to read 8 pieces of documentation. You need to represent a broad array of your programs. So when you're showing documentation from a programmatic area, if you have a great tobacco program, that's great, but Fab doesn't want to see all that being tobacco. They want to see the breadth and depth of what you do. You can reuse documents. The standards and measures are set up in a way that once it's been uploaded to eFab, you can sort of highlight the same one. And then sometimes to meet one piece of required documentation, it's going to take more than one document. And there's different ways to handle that. Some folks like to combine them all into one PDF and make a cover sheet. And some folks like to just have 4 or 5 things in eFab. And so Fab doesn't say which way is right or wrong. They're both acceptable. April will talk more about this in her presentation about doing a mock site visit, but these are just some general guidance to submitting documentation, which was formerly in the documentation guide, but is now just going to be in the standards and measures. I just wanted to show you really quickly a screenshot of our example documentation library. So we have pieces of documentation submitted to Fab by folks applying. Some of the health departments that submitted stuff that's on our website have been accredited, but obviously we don't have access to their site visit report, so I don't know if that piece received fully demonstrated and things like that. So we have caveats and all this stuff, but this is pieces of documentation that NATIO has reviewed and feel like meet the standards and measures, and so we make them available in PDF form, not for y'all to download and edit, but for you all to see what folks are doing for those measures. And then this is our documentation website, has some Fab materials, our guide to that self-study process. We have these really cool tools called documentation selection tools, which if you're at the beginning of your documentation selection process, I encourage you to look at them. They encourage ways of looking at selection other than measure by measure. So there's a lot of groupings of documentation and stuff dealing with communications or documentation related to programmatic work that you can think about collectively, so you don't have to go back and bug the same staff person 20 times once you discover something in domain 7 that was also in domain 3. So they're just some neat matrices and tools to have fun with your accreditation team. All right, questions about documentation? Okay, I think we're like right on time. I'm excited. So really quickly, engaging the local governing entity. The health department, the governing entity obviously has to sign off that they're in support of you doing this. So this is sort of the requirement of what they have to be. This is what they have to work on. Domain 12 is standard 12.1 is to maintain current operational definitions of the role. So this is where you show the laws that you are the health entity, public health entity. Standard 12.2 is provide information to the governing entity regarding the responsibilities of the governing entity. So that's like, okay, you as our board, this is what you have to do. And then standard 12.3 is you're showing the governing entity what the public health department overall does. So that's what you have to demonstrate for Fab. Typically in the field we hear about health departments having trouble with their local governing entities because they don't understand accreditation, they don't understand public health. The costs are obviously, barriers in some settings, and I don't typically mean the fees. It's more, you know, having a full-time staff person to do this, pulling folks off their other projects to work on the chip, things like that is where we see a lot of pushback from boards. And then, you know, because it's a new process, a lot don't see the benefits, but NATIO as well as FAB and other groups are working on collecting info related to that. These are things that we've determined throughout our work that need to be communicated to local governing entities at the beginning. So obviously public health, what it is, what we do, and then what the health department does. We have a presentation on our website, sort of an overview of accreditation, specifically focused at boards, so it includes like more info about return on investment, accountability, you know, those terms that business-minded folks like to hear. What their role is going to be, what it's going to cost, and then what the benefits and incentives are. In terms of benefits and incentives currently, there's obviously a few national organizations that are, you know, occasionally on an annual basis providing grants for folks working on this, and we're working with many others to, you know, encourage them to have other benefits and incentives coming out, and we're always happy to share the latest information we have. The biggest question I get in my work is what does it cost other than the fees, and unfortunately there's not an answer for that question. It varies so much depending on where you're starting and what you have in place infrastructure-wise, and at what point do you stop saying something is for accreditation instead of just doing business in a way that will help you get accredited. So I think NALBO has a few estimates, but at NATIO we just haven't found a good estimate for that. We do have some good estimates on time your AC will have to spend depending on where they are in the process. So if you have specific questions about that, you can come talk to me at a break and I can share that information. So again, when you go to apply, when you go to talk to your, you know, board, you need to communicate examples of what you're already doing, and you know, how you're working on, you know, QI and things like that to make this process smooth. And we have a few resources. We have the 101 presentation I talked about, and then we have these short videos that talk about 4 different components of the board. So if, you know, the QI piece is something your board wants to hear about, we have a short video that includes some input from health officials around the country, and then also just some facts about the process. Okay, so I'm now going to transition into the quality improvement section of my presentation. So before I do that, does anyone have any questions about accreditation? I answered everything. Okay, how many people felt like most of that was review? Oh, okay, a few, okay. And then how many feel like that was kind of overwhelming? Okay, only a few, okay, all right. When you guys fill out your evaluations, please sort of, you know, let me know where in the spectrum you felt like it fell, because I'm always working on adjusting this presentation so it's balanced for mixed knowledge groups. So I have some stuff to share about quality improvement, and then we're going to do an activity. So the first part of the QI stuff is in your packet slides, and then I have another presentation that isn't, but I will email it out to you afterwards. Okay. So the whole point of accreditation is not to just, you know, get a stamp of approval. It is to constantly be improving. So the idea here is that you are going, in order to get accredited, you're going to have to improve to some extent, most likely. And then you're going to, because of accreditation, identify areas where you can improve even further, and then you're going to get re-accredited, and then again, you're moving along this cycle of continuous quality improvement. I'm not going to read this to you, but in 2009, a group of brilliant people got together and actually defined QI in public health, because it was, you know, new to our discipline, and so we wanted to make sure we had a clear vision of it. And basically, it's using defined processes to improve activities and outcomes. So it's not just saying we're going to do this better haphazardly. We're using these processes to make things better. FAB's requirements for quality improvement mostly fall in Domain 9. You have to have a performance management system, which is how you measure, the indicators and activities you're working on. You have to have a quality improvement plan, and then you have to conduct quality improvement projects and demonstrate that you are doing that. A few years ago, NACCHO developed what we call, I think we've changed the title now, I think it's now just a roadmap to a culture of quality, but it is a really, really wonderful, amazing resource that charts this culture of quality improvement, so having your entire agency be functioning at a level where QI is just the norm in the culture, how to get there from the beginning, which is sort of no knowledge of QI. So in a minute I'll discuss the 6 phases, but this is what the website looks like, and it explains the 6 phases to get to that QI culture, and then resources to move from one phase to the next. And then this is just like a jump-in slide to my next presentation, which let me pull up. Okay. Anybody have any questions? All right, so why do we conduct quality improvement in public health? So quality improvements roots are obviously in the manufacturing sector. So this was sort of a developed way to, if you identified where a problem was actually occurring, how would you go ahead and either prevent or slow it down? And over the course of the last couple of decades, it's become entrenched in pretty much every industry, including finally, public health, we got there. And then it's a means to achieve efficiencies and improve the qualities of programs and services. And as Keith mentioned earlier, people are paying taxes for us to do this work. And so we are documenting to them that we can do it effectively. And then the sustainability of improvements obviously depends upon your organization's culture. So an organization's culture is the core values, how it develops over time. This shift in culture can be developed only by work of management and the whole staff to some level. Okay, so as we developed our roadmap to a culture of quality, we worked with a group of folks from the field to identify the foundational elements of this culture, right? So if you have this culture of quality improvement, quality at your health department, these 6 things are what need to be functioning well for this culture to be attained. And so if you can't read up there, I'm going to go through each of them individually. But the first foundational element, which this will be in the self-assessment tool that we'll go over in a second, is employee empowerment and commitment. So cultures of QI are only effective at health departments where you enable the success of all staff by having reliable processes and a supportive work setting. So if employees aren't empowered to do this, if every time they bring up a way to improve something they're shut down, they're not going to do it. And then also, which relates to the workforce development piece, staff has to be trained to know the knowledge, the skills, and have the abilities to conduct this work. The second foundational element is teamwork and collaboration. So you need to work on QI, teams need to be formed just sort of instantly, right? If you identify based on your performance management system that you need to do a QI project on a maintenance request process, a group needs to be able to form for that and work on this effectively and then disband. And so then that also leads to you need to share knowledge between the team that worked on that and other teams, and just everybody needs to be constantly sharing and collaborating. Color change, sorry about that. You need leadership to understand the components of quality improvement, what it is, and what they need to do. Leadership needs to be engaged and needs to be transparent in order for a culture of quality improvement to be in place. Customer focus. This has always been the primary focus of quality improvement in the manufacturing industry, and this is one that it's easier to think about abstractly than it sometimes is to put into place in our health department, especially because a lot of times it's hard to figure out who our customer is in some of the long range work we do. But at the very basis of the QI work you do, there needs to be thinking about who your customers are, and in that case it's our community and their improved health. The fifth foundational element is continual process improvement. So you need to constantly be identifying root causes, reduce variations and redundancies. Oh, are these slides in your packet? Oh, good, they are. Sorry, I thought they weren't in there. So these slides are in your packets. You need to, be working to improve quality, increasing customer satisfaction, and then there's several models for continual process improvement that exist. So it needs to be structured, not just, ad hoc. And then infrastructure needs to be in place, which includes a performance management system, which I could talk about for 9 hours, and I'm not going to put you all through, but this is not the refreshed model, but this is typically the performance management system most health departments use, the turning point framework. Second component of infrastructure is the quality improvement plan, which we talked a little bit about earlier. And then the third is this governance structure, so having a QI council, a QI team that meets, to monitor the status of projects and decides on new ones. Okay, so the activity we're going to do today relates to NACCHO's organizational culture of quality self-assessment tool. So this self-assessment tool is based on these 6 foundational elements that we just discussed, and we're going to separate into 3 groups and focus on 3 of those elements. And it's aligned with the QI roadmap. So the outcome of doing this self-assessment tool is to figure out where you are on the roadmap. So let me just advance for a second. Okay, so these are the 6 phases on the roadmap. So phase 1, so phase 1 is no knowledge of QI, which obviously you all are here, you've heard of the concept, you're beyond that. Phase 2 is you're not involved with QI. Phase 3 is that you're doing it informally or ad hoc. Phase 4 is that some programs have it formalized, but not all do. Phase 5 is where QI is part of your formal agency activity, and then phase 6 is QI culture. So a lot of you can probably look at that roadmap and say, I think I'm somewhere between 3 and 4, or maybe we're at 5. But we heard just a lot of demand in the field of how do I document to leadership that they all think we're phase 5, but really I know we're phase 3, etc. So we developed this tool because of that, and that's what we're going to work on today. So we have on our website we have the whole tool, which goes through all 6 of these foundational elements. And then we have a Word document version of it, so you can type it up and share it with leadership. And then also a PDF, so you can print it out pretty to show people. And the ways that we encourage folks to use this is to go through some of this with upper management. The whole tool would probably take a couple of hours, and so they probably won't want to do the whole thing. But these middle managers and program managers often will enjoy doing the whole thing because it gives them a clear picture of what's going on. And then project managers and people like that, seeing how QI fits in with the work they're doing. So I'm going to So what we're going to do is, when we were envisioning the setup for this training, we were envisioning sort of round tables. So it's going to be a little, fun, but we'll make it work. So we're going to need 3 groups because I have 3 foundational elements for us to work on. Let me get slide 21. Okay. And Dana, April, and I are going to be just sitting there to sort of listen to your discussion. Obviously, this is going to be up to you. So we're going to pass out. Each group is going to have 1 copy of the whole self-assessment tool, and that's just for you to look at if you're interested. You don't need the whole tool for this activity. And we're then going to pass out copies of the questions that go along with foundation element 1, foundation element 2, and then foundation element 4. It's like employee engagement. I forget which the 3 are, but we'll see them in a second. And this tool is meant to be done with your QI team or a group of folks at your health department to think about where you are for each component of this foundational element, right? So for terms of the activity today, we want you all to discuss as a group where each of your agency falls in a few of these questions that are going to come up. And then we might not have time for a report out, but plan on reporting out one person's stories of where they are. So if you don't want to share about your health department, you don't have to, but hopefully someone will be willing to say where they fall for a certain question or two. So there's going to be, 15 to 20 questions on the sheet. You're not going to get to all of them, but we want you all to see what the tool looks like and how it can be used to facilitate really good, rich discussion around some of these foundational elements of QI. So I think we did 25 copies of each, or 20? 20, okay. So this middle group might have to spread out a little. So I think these two groups are probably bigger than that third one, but we'll just use like chunks of the room for now, and then if you don't get a copy, move to another group, and hopefully we can even out. So we'll pass those out, and maybe we'll split into, we'll see. If your group is too big to, talk from you to you, you can split up into smaller groups and have discussion. But look at the tool, discuss some of the questions where your health department applies and what you think about it. So, okay, all right. So let's do, all right, so you all will be foundation element 1, and you'll make sure